Well, as you can see, we're talking about disease surveillance and control, and of course, who better to address that with us this morning than the Nigeria Center for Disease Control and Prevention, which is Nigeria's public health institute with the mandate to detect, prevent, and respond to diseases of public health importance. Dr. Ifedaya Adetifa is Director General, Nigeria Center for Disease Control. Thank you for joining us this morning, Doc. Well, perhaps it's okay for me to begin by saying, hey, it's been about a year or thereabout for you now in the saddle. How's it been?
It's been interesting. Thank you for having me to start with. It's been almost a year of, whirlwind challenges, and it has been interesting so far. Which is why I'm still here.
Well, thank you again for being here and for what you do. Perhaps it's also good to ask you what the challenges of the job are for you. Literally managing the surveillance and disease surveillance and control for 200 million plus people. It's no mean job.
Yes, indeed, it is no mean feat to have to serve 200 million people across 36 states and the federal capital, and doing that through the platform provided by what is a relatively young agency, which over time has managed to punch well above its weight despite the challenges in front of it. But we continue to push to scale up what we need to do to really ensure that we have impact and have a presence that is felt by all of the citizens that we serve. The challenges there, of course, include every activity that we need to do needs resources. So financial resources are important, but even when you have financial resources, you do need the human capital. You need skilled and highly motivated workforce, and you need not just a few of them, but enough of them to achieve coverage and to achieve scale. The other challenge, perhaps, is people do not often relate our health security to our healthcare system, but the healthcare system as a whole, through very well functioning primary health care and universal health coverage, is actually the foundation for health security, because health security certainly depends on having a resilient health system. And we know that there's been quite a bit of neglect in that area for decades, and it will take more than the efforts of one government in even 2 terms of office to close that gap. But we are seeing the needle moving a bit in that aspect with revitalization efforts for primary health care, with the changes into the national insurance function and package, and we hope that that will continue to make sure that citizens have unlimited access to care and therefore are able to contribute to surveillance. It makes it easier to detect signals of outbreaks, and hopefully access to primary health care also is quite closely linked to the uptake of vaccination, and the uptake of vaccination with high coverage then also will mean that we will have less of a challenge with vaccine-preventable diseases.
Well, Dr. Adetifa, a natural question that comes to mind now when you talk about personnel, capacity, one question that comes to mind is that of partnership with the states. I'd like you to speak to that partnership and other critical partners within the Nigerian system that you have to work with, that you have had to work with, that you are having to work with. You are the 3rd DG of the NCDC over time, and you perhaps have been in the system for long enough to know how well or not those partnerships, particularly with partnership with the states, has helped to deal with some of these issues. Because there are those who would wonder, look, we shouldn't be having issues with Lassa fever. We shouldn't be having issues with some disease because we know it's going to happen in a year. Just recently, the flooding took over a number of states in the country, and we hear that more of it is going to come. And naturally, diseases will follow when the floods abate. So what kind of partnership is there with the states? Is there a system established, or do you still have pushbacks with some agencies or individuals in some agencies at the state level?
Well, it's a very important question, and I think it's important that I highlight that, for all of the success that the NCDC that's been attributed to the NCDC, none of this would have been possible without our close collaboration with our state partners. We are based in Abuja. Yes, we can deploy when it's required to provide support in states, but that's essentially what it is, to provide support. We do not have a standing army that can be deployed across 36 states and the federal capital at the same time. Okay, so we depend on the state ministries of health. We depend on the state departments of public health. We depend on the state epidemiologists, and of course the disease surveillance and notification officers and the lab focal persons and all of the like. So we are in constant communication with all of these people that I've mentioned to varying extents. We certainly have regular interactions with our state epidemiologists to discuss matters that are within the remit of the Nigeria Center for Disease Control and Prevention, and to understand what challenges they may have in, of course, implementing or carrying out their statutory function. So I don't have any complaints as far as cooperation or collaborating with the states. But I think it's important to also highlight that just as there are challenges in the at national level, there are also challenges on the state level. The states vary in terms of the manpower that is available, in terms of the size of the state epidemiologist unit, in terms of the number of expert personnel that are there. There's frequent attrition, as everybody knows, frequent transfers in and transfers out. So that also is a challenge for sort of departmental or institutional memory, which is one reason why, for example, whether it's state-led or federal government-led, there's often a need for repeat and repeat training, because sometimes some of the people that you've trained and built their capacity to do particular functions then are no longer in that position. And of course, there's the challenge of financial resources. Until recently, there was no state that had a budget line for emergency response and even emergency preparedness. And as a result of lessons learned from COVID and the advocacy by partner organizations, civil society organizations, at least 2 states have budget lines for emergency response. So states have, this just to discuss some of the challenges that are common to all of the states along with the national government. And of course, then there will be state-specific challenges that all of these teams have
Dr. Aditifa, I find it very interesting what you just said now about states not having budget lines for emergencies. Could you please expatiate on that, and how crucial is it?
Well, it is very important. I've had to contend with a number of public health challenges, maybe in the last decade. But I'm sure you will agree with me that perhaps it's not until COVID in particular that the term national health security or global health security became a bit better known or well known. Obviously, the experts or the practitioners in the field would have been aware, but this was not the sort of consciousness of most of the ordinary people and our political leaders in preceding years. So with the advent of COVID, that's now on everybody's lips, and everybody recognizes that countries need to be responsible for their own destiny, so to say, as far as their health security is concerned, even while that contributes to global health security. So if you think about it, in recognition of this and some of the challenges we've had in previous years, having to respond to Ebola, having to respond to monkeypox reemergence, having to respond to those outbreaks of meningitis and the like, perhaps these were stimuli that also led the government to finally sign into law the acts that established the Nigerian Center for Disease Control and Prevention in 2018, and then brought, which basically was an effort to bring better coordination, more efficiency, and leadership to things that relate to national health security and the threat of communicable diseases to public health. So if, that is the journey for the national government, which means, again, to an extent, despite the best efforts of state ministries of health and their respective departments of public health and the state epidemiologist teams, they are in some ways slightly behind in that journey. And just like it's, even at national level, we had not had an emergency response fund or money kept aside for emergency function for until recently. This is the same situation that is in states. But as I said, in realization of the need to have preparedness and response for threats within state borders and, of course, across state borders, and also in recognition that we would only be as strong as our weakest link in the country, we are quite keen to help our state partners to understand also their own responsibilities to put in place things to assure health security, even whilst contributing to our national health security. And we have a lot of partners operating in that space, especially among advocacy groups and all of that. And it's actually pleasing to see that as a result of their activities, as a result of also government realization, national health security budgets and releases have increased. We've got a national action plan for health security that is also funded to an extent and is being implemented. And we are working with our states, our partners, to also ensure that they do that, of course, a scaled down version of that in their respective domains, so that we
Dr.
all achieve. Yes.
Just a second. So, so far, as you said, and perhaps many of them are working towards including emergency budget lines in the budgets, emergency, funding for emergencies in their budgets going forward. But for now, you said only 2 states have budget lines for emergency. Is that correct?
Yes.
Okay. Now, the threats of known diseases and unknown diseases are high. We understand that Ebola is in Uganda's capital city, and we have dealt with Ebola before. We were able to fence it off, even though at the risk of the lives of some of our personnel in this country. We also know, and you are definitely aware, that COVID figures are rising in Europe, the UK perhaps to be precise, and a number of other countries might be battling things that hopefully will not, but is highly likely will come because we are such an open economy and all of that. So if states do not have that, are they even aware of the risks? Because we have international airports in Lagos and in Abuja, and they can go anywhere to any part of the country from there. So how do we get ahead of those emerging, God forbid, but almost certain onslaughts of these diseases if we do not have these budget lines?
Well, it's desirable to have the budget lines and to have the releases, which shows some proactive thinking. But we also need to recognize that governments have perhaps not done too badly in mobilizing resources when they are required for emergency response. We just want to move a step away from that to make sure that whatever additional lag time that is there when you have to wait for resources to be mobilized before you respond to conditions is completely removed as the next step in our growth. But in terms of awareness, with us working with state partners and with port health authorities, for example, we do work out plans for responding to these threats, especially those that may come in through our international airports, as we are currently doing as part of our alertness or of the raised alert level for Ebola.
Well, that's Ebola there. We have dealt with that before. Any lessons from the past that might still be relevant?
Oh, certainly the lessons are there, and there's institutional memory, and believe it or not, there are still quite a number of people who were part of the response there that are still in the system. And of course, going from Ebola, I've even had to contend with other outbreaks and even provide support to other countries in the continent. So in terms of the human capacity to respond to Ebola, that is there. And we are in a better place, perhaps, than we were when Ebola first arrived. So it's a condition we have seen. It's a condition to which we have some familiarity, even if it's not as frequently occurring here in Nigeria as it occurs in East Africa and Central Africa.
Okay.
But the human capacity is certainly there.
Okay. How about COVID? We understand there is a 14% jump in the UK, and knowing the relationship between Nigeria and the UK is certainly something that could be giving you some concern, isn't it?
Yes, so we remind citizens that the COVID pandemic is still there and has not gone away despite our efforts to return back to what the normal life or whatever the new normal is. At this time, we are aware that the COVID situation across the world is as varied as there are many countries in the world. The increases in Europe and in many countries in the Northern Hemisphere will definitely happen as they go into winter. And winter is a period where you have increases in respiratory pathogens. So whether respiratory diseases, so whether historically what they dealt with was flu. So the flu season is approaching. All other respiratory diseases like COVID will probably also increase. But I think what we need to keep in mind is that one of the successes of public health in terms of COVID, as a result of vaccination, as a result of natural immunity, is that we now seem to have achieved a full disconnect between number of cases, numbers of hospitalized patients, and deaths. And that's an important thing to highlight. Of course, you can't totally ignore number of cases, because if you get a large number of cases, even if they are not dying and they require hospitalization, then it means that your health system can be quickly overwhelmed.
Well, Dr. Adetifa, you listened to the conversation we had earlier about cancer, breast cancer, and that the awareness level from the NGO representative of the NGO that came to speak with us, the awareness level is very low. Perhaps it's a case for a number of other illnesses in the country. But speak perhaps, if you can, specifically to breast cancer. It's the month of breast cancer awareness. What is your understanding of the level of awareness in the country, and why do you think it's so low?
Well, if we're speaking specifically about breast cancer, of which I must start off with a caveat that that's not my area of expertise, but I have had relations who have had cancer and breast cancer. I think part of the challenge we need to sort of recognize is that for a long time, the focus in the country and in our part of the world has been on what then was the obvious burden of infectious disease conditions, of malaria, of meningitis, of even those that are epidemic prone, of cholera, and all of that. So in lower, middle, or less resource countries, most of the burden of or the disease components that are seen has always been communicable. Okay, but in the background, the non-communicable diseases, which include cancer, which include cardiovascular conditions, cerebrovascular conditions, speaking about strokes and all of the things related to that, have been slowly creeping up in the background. And of course, with lifestyle changes, with urbanization, with all changes in diets, increases in level of sedentary life and all of that, we are seeing, of course, an increase in non-communicable diseases, including cancers and the like. And they are beginning to approach sort of equal weighting with communicable conditions. But because we've not paid as much attention to them in the past as we have done to communicable diseases, we're still somewhat behind in terms of awareness and in terms of the effort that needs to be put into community engagement and risk communication for non-communicable diseases, including cancers and breast cancer in particular.
Well, at least you've spoken quite, impactfully on it, even though you said it's not your area of specialty. But then, another one that comes to mind are what one would call seasonal illnesses. I don't know where we'll put cholera in that, in your frequent or occasional advisory that you recently published, that NCDC recently published. We are in a cholera outbreak. And I'm wondering, if this wasn't preventable. The natural question that will come to me about that would be, what role the local governments or the health officers or environmental officers at the local government level could have played in ensuring this doesn't happen, or at least we curtail it to the barest minimum?
Well, cholera, I'm glad you asked that question. Cholera is something that keeps me awake at night, despite the fact that it's a condition that all of the solutions to preventing it and responding to it are actually well known. There's nothing new. We don't need a new vaccine. We don't need a new treatment. The challenge with cholera is all about water, sanitation, and hygiene. The absence of potable or safe water supply in many communities that are affected by cholera, and the practice of open defecation, which also is a signal that sewage is not properly managed. So the seasonal nature is one that comes from when the rains then come. So what happens is in the rainy season, and when the rains become really established, all they do is that they wash all the we've been practicing open defecation. So they wash everything into the water sources. So the water sources become contaminated, and people then consume that and use that, and then they come down with cholera. It's very simple, yet rather distressing that we continue to experience this disease, not as small outbreaks, but as really large outbreaks as we have seen. So if we had the required investments in water sanitation hygiene, including, community dams, boreholes, just safe water. If we stopped practicing or reduced significantly the practice of open defecation and managed our sewage and other effluents better, we would have an instant impact on cholera. And this is where, as you say, provision of water, sanitation, and hygiene is a local government and a state function. And we need, despite the neglect that to expansion of water supply and water works that may have happened for decades before now, there is now a need for really significant investments in that space if we are going to have impact and drastically reduce suffering and death that is attributed to cholera.
Well, I'm glad you mentioned, the local government system there. It will seem like I've become some sort of advocate. What's the body language, in your opinion, of governments at from various states about restoring those environmental offices at the local government level?
Well, we are speaking to partners and even at national level to look at health, human health, and the interventions that are required to preserve human health from something called a One Health perspective. And the One Health perspective or strategy is one that recognizes that human beings, animals, we all coexist in the same environment. And anything that happens in any of those sectors, whether it's in the environmental sector or happens in the animal sector, and even in the human sector, will have impacts across the chain. So if we achieve what we need to achieve is a complete change in mindset where these various sectors, even though they're in different ministries and different departments, they need to come together more often to jointly plan. That's to always, when you're thinking about environmental activities, always think about what impact it may have on animals and humans and what changes in animal health and human health may have on the environment, and then bring all of these other partners on board when you are making your plan so that you can get that input. We, at national level, have some relatively good coordination between our colleagues in the animal health sector and in the health sector. And we are trying to ensure that that same relationship it becomes as strong between both partners and the environment, which is slightly behind. And an area of growth for the NCDC and for all of the One Health partners as we go forward is to also establish this philosophy, this pattern of work all the way down to our various subnational units. And that needs quite a bit of work, but the idea is welcome. There's enthusiasm for it. It's just a lot of work that needs to be done in that space, including, the awareness, the retraining, the monitoring, the evaluation, just to make sure when you're trying to sort of, this is akin to implementing behavioral change or a change of thought or philosophy, and that needs some time to fully graft and then to become the new normal.
Well, you've told us a lot today, and I believe that so many people have been better educated. Dr. Ifedayo Adetifa is Director General, Nigeria Center for Disease Control and Prevention. Thank you so much for being a part of our conversation this morning. Congratulations on spending 1 year in office, and all the best.
Thank you very much for having me. And at the NCDC, we certainly appreciate our partnership with all of our media partners. You make our work easier, so thank you.
All right then, thank you. So Sunrise continues right after now with another topic. Please stay with us.